what's happening in our blood does not reflect what's happening in our cells. And this is something that actually Brown and Goldstein talked about several different times, that looking at our blood for lipoprotein details of cellular metabolism is like looking through your garbage to see what's happening in your house. There's just not a one-to-one relationship. Every cell with a nucleus in our body is making cholesterol on demand. It's absolutely obligatory for life. And so if we have a low LDL cholesterol, and it got that way because we were clearing particles very efficiently after they've been made normally, we don't know of any downside of that.
Anyway, we have the pleasure of having Dr. William Campbell here today to talk to us about what he does as a lipidologist, and I'm excited to have him on. We had a nice conversation at KetoCon a few weeks back, and I spent about close to an hour chatting with him, so I wanted to go over some of this stuff and some other things today. So, Dr. Campbell, let me unmute you real quick, and you should be able to unmute yourself, and then we can get started. There we go.
So, hey, Bill Cromwell, good to see you.
Bill, it's good to see you, Dr. Cromwell. I apologize, I mispronounced the name there, but we had this really interesting discussion on lipidology and risk factors for cardiovascular. That's what you do. And just by way of background, how long have you been doing lipidology, and how did you get into that?
Yeah, so I've actually done lipidology for 33 years now. It's been a long time. So I got into it actually in a pretty easy way. I was a physical chemist, went to medical school, and asked the question, what kills people? And the answer I got was vascular disease. So this is back in the early 80s. Question was, what can we do to stop that? There weren't a lot of definitive answers at that time, but one of the things people talked about were lipoproteins and the cholesterol carried by them. And I said, well, you measure that, right? We measure that. So maybe that's what I'll do with my career. So I'll do something related to lipoproteins with the intent of understanding vascular disease, and maybe in the future we'll have something we can do to mitigate that. And so really that's the way I got started.
And as far as I guess I don't know where you get, maybe from internal medicine or cardiology, or when you get into lipidology, because it's not like the traditional sort of thing most people go into. I mean, it's I guess it must be a fairly small, especially I know guys like there's what Thomas Dayspring is a fairly well-regarded lipidologist, or has done a lot of work in that. But what is your day-to-day practice? I mean, are you just dealing people with lipid abnormalities, from that? I know you've got a company now where you're stratifying cardiovascular risk based on a number of factors, but what does a day-to-day look like?
Great question, because actually every week's different for me. I have worn many hats through the years. My clinical practice is restricted just to lipidology. So I see folks who are referred from internists, cardiologists, family docs, endocrinology, pediatrics. The basic story is numbers are bad, can't get better, or numbers are bad, people can't tolerate medications, or numbers are bad and on medications, people aren't getting where they need to go. People sometimes want a second opinion. Can I get off medicines? Some questions of, do I need medicines in the first place? So all of those are fair game for the types of patients that I see. Another hat that I've worn for many years is a research hat. So there's a lot of my time spent with data analysis, research publications. Prior to COVID, a lot of my time was spent on the road teaching in grand rounds or other settings. It's beginning to come back now, but you can imagine for a couple of years that dried up a lot. So that's my kind of week to week, is some combination of patient care, research, teaching.
If you talk, and again, I'm not going to say, I don't know most lipidologists, but it seems to be that most of the lipidology sort of philosophy is, obviously LDL cholesterol, particularly APO-B, is bad. The more we have, the more likely we are to have cardiovascular disease, and therefore we should do everything we can to lower that. And I don't think you differ significantly from that opinion, but it's often through things like low-fat diets, vegetarian, plant-based diets, and I still promote, I guess, from what I understand, in many cases, a lower carb approach. Why do you differ than I guess what I hear from most folks doing lipidology?
Well, it's a great question. I think we have to unpack it by taking a few steps back. So you brought up the paradigm of atherogenic lipoproteins. So these are the particles that carry cholesterol that are injurious to the walls of our artery. And most commonly, it's the APO-B as in boy pool. People are very familiar with APO-B as an alternate measure of how many of those injurious particles you have. One of the challenges is that cholesterol as a measure of LDL is imperfect at best. The amount of cholesterol in particles is highly variable. And a lot of people that have the biggest need for improvement and yet the least amount of visibility from a lipid perspective are those with insulin resistance, metabolic syndrome, or type 2 diabetes. So the story there is that they have a lot of these APO-B containing particles, but the amount of cholesterol per particle is much less than expected. So as a result, they end up with LDL cholesterol, which is unremarkable or maybe even looks good. Triglyceride levels are typically somewhat elevated. It doesn't have to be crazy high, but 150 and higher is very common. So these people are a ticking time bomb from a lipoprotein perspective. They have lots of injurious particles. They have insulin resistance in most cases underlying the reason why they have too many of those particles. And that begins to get us to the point of, well, what do we do about this? To a lipidologist, we typically think of production and clearance. So if you have a lot of these APO-B containing particles, did you make too many? Did you not get rid of them after you made them, or both? And with insulin resistance, metabolic syndrome, type 2 diabetes, you're talking about a mixed overproduction clearance defect. And that's the reason why some type of carb-capped intermittent fasting type approach usually does a much better job of addressing the root cause of their physiology than, say, a low-fat diet.
Yeah, and so just to maybe dumb it down for a dumb old orthopedic surgeon like me, what you're saying is, if you have a pattern which is associated with insulin resistance, typically high triglycerides, perhaps low HDL, you can have variable amounts of LDL cholesterol, even normal to low normal amounts, and still be at significant risk. And that's why we see a lot of cardiologists and cardiothoracic surgeons say, hey, I see a lot of people on the heart attack, going in for CAS and open heart surgery that had normal LDL cholesterol. And that's that cohort, correct?
Correct. And this kind of has tentacles into a variety of communities. Cholesterol is just a marker of the particles that carry them. The particles are the real problem. So if the amount of cholesterol in a particle is never the same, you can get situations where people's cholesterol values don't look so bad, and yet it's missed the boat. The problem is the number of bad particles is still quite high. And this feeds into a correct but controversial narrative, and that is that cholesterol is not always a very good marker of cardiovascular risk. That's a true statement. And so when people look at that, they say, well, how do I understand that? Does that mean that cholesterol doesn't matter? Does that mean that LDL doesn't matter? Does that mean that the measure I'm using, LDL cholesterol, is imperfect, and therefore I need a better measure so I don't get put on the wrong track? So this is, I think, an important analytic conversation, what we measure and why what we measure matters. So I don't have a problem with people who look at the cholesterol hypothesis, quote unquote, as imperfect. That's true. But what's not is the case is that the number of particles is irrelevant. It's very relevant. And the key here is how long have people been exposed to a burden of particles that would increase risk of blockage in their arteries. The longer, the higher, the worse.
So we could conceivably make an argument that someone had a higher cholesterol but better insulin resistance, and actually have less risk than someone who had really bad insulin resistance and slightly lower LDL. It just depends where those numbers overlapped, and I guess, and I certainly, when we look at the APO-B, or it's APO-B 100, APO-B 48, it seems like there's a variable amount of these different particles, whether they start with the chylomicrons, which are like triglyceride rich, typically all the way down to the Lp(a), which tends to be predominantly cholesterol. Correct me if I'm wrong on that. But, those things can variably increase or decrease and not be completely concordant with just the cholesterol measurement. Is that fair to say?
Right. So the APO-B pool is interesting because you said that there's an APO-B 100 and APO-B 48. That's true. What's curious is that APO-B 48 particles, chylomicrons, contribute about 2% to the total APO-B pool. 98% of the APO-B pool is the B100 particles. And of the entire APO-B pool, 90 to 95% of the APO-B pool are indeed LDL particles. So when we kind of unpack this, there are many types of APO-B particles, but the lion's share are LDL, and a very small amount are the B48 that come from the intestine. So as a result, we're basically saying the simplest answer is the more APO-B containing particles, the more risk we have. And just physiologically, the lion's share of those are B100 and their LDL.
Yeah, and so if we can say, I mean, I think it's a very fair statement to say the more the more APO-B particles you have, the more cardiovascular risk factor you have, all other things being held equal. Now, not all other things are held equal. You just mentioned things like insulin resistance modifying that risk. I have a question to you about, there's a particle size, and then there's the actual vessel itself. And the blood vessel itself, the artery, is going to be increasingly at risk for I guess, I call it vascular stickiness, for lack of a better term, based on the proteoglycan content and the glucosamine tails that are on there. And there's things that modify that. I did a little, fair bit of research on this, and I see the proteoglycan content can be modified by certain drugs, antihypertensive medications, diabetic meds, calcium channel blockers, and certain nutrients modify that. So is there some, can you say that we can change the qualities of the vessel themselves by diet, by exercise, by medications? Is that a fair statement?
To some degree. A lot of the proteoglycan that is part of the atherogenic process is the matrix protein in the wall of the artery. So if we think of an artery as a tube, and keeping the tube open is important. In an arterial system, there's a pulse pressure. And so when there's a higher pulse, it kind of stretches a little bit. And when the pulse pressure goes down, it relaxes a little bit, but it doesn't collapse on itself because we have this matrix in the wall of the artery, proteoglycans. And that basically forms a web, almost like a catcher's mitt, right? And so the more densely this web overlaps each other, it forms a tighter surface that can trap these APO-B containing lipoproteins. So when you look at just the architecture of an artery, as it's in a straight laminar flow, there is a lesser weaving, if you will, of proteoglycan than at branch points or areas of turbid flow. And where you have that, you have a greater density and overlapping of proteoglycans. That is why you basically, in most cases, see atherosclerosis begin as a focal disease process. Spots here, spots there, where there is a greater density of this network of proteoglycans that can trap APO-B containing lipoproteins. Now, affecting that is something that has got some early research. We're not really sure exactly how much we can affect that, but there are some things that can affect proteoglycan in the artery wall. The chief driver, however, is the number of particles entering in the first place. The more in circulation, the more they enter the artery wall. The more they enter the artery wall, the more there's a chance for them to be retained. And so this idea that particles that are retained are the ones that can contribute to atherosclerosis is an old theory that started back in the 70s and 80s called the response to retention hypothesis by Dick Sinclair and others. And that's been shown to be a valid part of, but not a complete explanation for atherosclerosis.
Yeah, we talked to you, and I had mentioned like my sort of numbers. Like I said, I had I think an LDL cholesterol, 130, 140, not ridiculously high, but certainly higher than a classic person would like to see that under 100. And some people much, much lower depending on your overall history. And, other mitigating, like we talked about some other mitigating factors. We know that, like, for instance, VO2 max predicts atherosclerosis. So if you have high VO2 max, you're less likely to have atherosclerosis. I'm a guy setting world records. I've got a pretty good VO2 max. And I've had a CAC score, which was 0 also, which, again, when we look at the net balance of this, how interested are you in imaging? Do you think that, because, my question is, let's say I go on because there's, obviously you deal in cardiovascular disease, and there's a lot of things that happen in medicine. There's arthritis, there's mental health disorders, there's cancer, there's autoimmune disease, there's gut issues, which I see in this whole community. I can tell you there's people in here that if you told them that your risk for cardiovascular disease has definitely increased, some of them would deny it, clearly. Some would say, I feel so good, I can't believe it. And others would say, I don't even care because I feel so much better. My quality of life is so much better that I would rather feel like I do today and not have this miserable, crippling mental health disorder and take my chances. That's there, and I think we can't ignore that. But what do you think about just a belief that we should just lower cholesterol as low as possible? And there's people out there that certainly believe that. They think everybody should be on a statin, everybody should be on perhaps on a PCSK9 inhibitor. And do you have any concerns about the conflicts of, decreasing your risk for cardiovascular disease, but perhaps diminishing quality of life or increasing your risk for other things?
It's a great question. And I like the way you set that up because, we are a total being with lots of other factors other than just what's happening in our vessels. And that's, I think, critical. I hope I do that with my patients, that, we have what we call a shared decision-making conversation, which is the totality of them as well as whatever their cardiovascular risk may be. So this kind of gets us into the topic we were talking about at KetoCon, and that is, how do you try to individualize your approach one patient at a time? There are several parts of that conversation. One you brought up is imaging. I think imaging is critically important. Let's take a patient that I see frequently. Somebody who comes to see me for the first time and they have a history of numbers that aren't great. One of the things I'd like to understand is how long has that been the case? And I can't tell you how many times people are unaware of how long their lab values have been potentially bad. They just got a bad value. They got sent to me. So I really don't have any context of how long has this been the case? What's causing the abnormality in the first place? Should they be worried? The typical idea for most risk factors, be it smoking, hypertension, lipid disorders, is how bad for how long. The smoking's easy. People know when they started smoking, they know how much they've been smoking. So that has a dose exposure to it. And the same we think is true in general for APO-B containing lipoproteins. In general, the higher, the longer, the worse, with lots of mitigating factors. But if I don't know, if somebody comes to me with numbers that are not great, one of my first questions is, how are your arteries? Do you have plaque in your vessels? And if you have plaque, how much plaque do you have? If you have a very high plaque burden, especially at a younger age, a process has started that needs our attention. And that becomes the focus of the exercise. It's really not about what number I want to get to. What number do you have? It's, are your vessels showing me a disease presence that either we are unexpected or is expected? And so I do think imaging is one of the get out of jail free cards for some people. And I think it's a mitigator of how aggressive should I be for others. What do I do if I have a 70-year-old lady who comes to me, and this happened not long ago, saying, I don't want to be on a statin. I'm here for a second opinion. Well, who said you need to be on a statin? My doctor. The story was she had high LDL cholesterol. I asked, how long has it been that way? She said, you're the first doctor to ask. She pulls out a 3-ring binder, starts flipping back, and it started 5 years prior to seeing me. I said, well, has anybody checked on other reasons why they could be high? She had a TSH of over 50. She had hypothyroidism. We fixed her hypothyroidism. Her LDL melted back down to normal. Oh, and by the way, a coronary calcium score of 0. And I said, so good news is you don't need a statin. And a 0 means you're actually in really good shape for your age. And you can opt out of a statin for at least 5 more years. You can get 5-year, increments of checking a coronary calcium if you like. But this is the case where knowing a little bit more about the patient, digging a little bit deeper, looking at the vessels, looking for reasons why values can be abnormal and fixing root cause, I think is a better approach than what used to be the idea that statins weren't a product to be worried about. Just put it in the drinking water as low as we can go for everybody is a good idea. Obviously, that has limitations.
There's evidence that even young people, like even little kids, start developing evidence of these streaks, these early plaques, and some of them have very, very low cholesterol. 20 and 30 and 40 in some cases, particularly when they're very, very young. Why are they developing that? Why do you think that is?
So the data for that, as you know, comes from a couple of different places. One was individuals killed in war, the Korean War, Vietnam War, young men who went through an autopsy after death and a lot of fatty streaks, in some cases early plaque. And then there were kids that were killed in auto accidents, the P-Day study, where these very small children under the age of 5 had fatty streaks. And that got us thinking about, factors that can start microscopically, but it takes a very, very long time for a fatty streak to develop into something that we would identify as an arterial plaque. Some of that is genetic, and we have a very poor handle on the genetics of atherosclerosis. There's a very large biobank in the UK biobank with 500,000 individuals. They've fully sequenced the genome for all of these people. So they have big data and big computers and big science and AI. 6,500 different small nuclear fragments have been associated with some degree of risk for or against atherosclerosis. And so those researchers have looked at multi-markers of trying to integrate all 6,500 SNPs in there. And what do they find? It's a bell-shaped curve. Some individuals are on one negative extreme of the curve where they have a lot of risk. Other people are on a very positive extreme of the curve. And guess what? If you look at individuals who are extremely favorably predisposed, they can be in a category with significant risk factors, smoking, hypertension, terrible dyslipidemia, and they are buffered. They do not show evidence of atherosclerosis as we would expect. Other individuals who have very unfavorable multi-marker scores get into very early vascular disease in their 30s. They have very few, in some cases, traditional risk factors. I guess once a quarter, I get people referred to me who are going through their second or third stent or arterial intervention in their 30s. They have multiple vascular beds with disease. And yet when you shake the tree, you don't see traditional risk factors. You don't see high APO-B. You don't see high LDL cholesterol. They're not smokers. They're not hypertensive. They're not diabetic. And so that leaves us scratching our head is why are these people showing up with clinically significant disease at a very young age? We call it genetic because we really don't know what else to call it. So there's a lot of unknown out there. And it's very humbling when you see somebody like that. And they say, well, what are we going to do? Well, I'm going to suggest that we treat in ways that affect the natural history of the disease because you've got it. But I'm not guided by particularly abnormal lab tests. I'm guided by the fact that despite what you're trying to do to get this under control, it's not working. So kind of a long answer for the fact that we've got a big bucket of unknown that we're still trying to figure out. And then we've got the major risk factors, which generally are going to help us understand people's risk. But there can be cases where you can have a single risk factor. Let's take familial hypercholesterolemia. FH is a genetic disorder where people have high LDL from a very young age. And most of them, if you do nothing for them, will have very early vascular disease, but not all of them. Some of them will be able to get into their 40s, 50s, and 60s relatively unscathed. So there are factors in those people that are buffering their expression of what we would expect to be a high-risk state. And that's kind of the mosaic of people that we intercept every day.
And I suspect the answer is going to be the same, but there are people that go on low-carb diets, ketogenic diets, carnivore-style diets, and nothing really happens to their LDL. I'm one of them. It didn't really affect mine. Mine has always been about the same. Diet didn't really make much of a difference to me, at least from what I was eating before versus what I eat now. There are other people where, and I can tell you there's somebody in here who's been eating nothing but meat for 4 years, and his LDL cholesterol is like 90 or something like that, or 100. It doesn't seem to affect it. And yet there's other people where it just skyrockets. Do we know why that is? Is it just down to genetics, or can you think of why that might be?
Well, this is where Dave Feldman and a few other folks have spent a lot of energy trying to understand why do some people have this very brisk LDL elevation and others don't. There are a couple of different theories out there. One of them has to do with the amount of fat intake in diets versus just meat, right? So some people who exceed a fat threshold, either a total fat threshold or a saturated fat threshold through a couple of different mechanisms, can increase their LDL dramatically. Dave Feldman has an energy model which might explain why people do that. Other observations have been that in certain settings where there's a very high fat intake, you can actually downregulate LDL receptors. And therefore, you can't clear the LDL which is present. It may be a combination of both. What I've seen in people, though, is that if it's a dietary influenced increase in LDL, in many cases, it can be unwound by going into a little bit of a diet modification program where you're either curtailing some of the fat, increasing some of the carb, changing the macros around. And you can, in many cases, get to a point where the impact of diet has been greatly reduced, so that if individuals have an LDL cholesterol of 200 plus, that wasn't the case prior to adopting a certain dietary practice, they can just retool their macros in a way where they get back to their baseline or pretty close to their baseline.
Yeah, why? There was another paper that just came out. Maybe you've seen it. I think it's very recent. A guy named David Diamond who calls himself LDL-skeptic, so you can tell where his bias is. And Ben Bickman and I think Paul Mason published a study. But basically, he was talking about, should we put people on low-carb diets on statins? And basically, they listed a whole thing of, these are all the things that a low-carb diet improves: obesity, inflammation, HDLs improve, triglycerides improve. And they listed like 10 or 12 things. And they said that on the concerning side is a fairly consistent rise in LDL cholesterol. And they were like, do these things balance each other out or outweigh one or the other? I know you came up, I believe you were critical in the development of something called the LPIR score, if I'm not mistaken. And when we look at overall cardiovascular risk, can we say what the most important thing is, or is it still APO-B above everything else, and nothing else is as important? What are your thoughts on that?
Well, it's a hard question to unpack because it's going to depend on a number of different variables, including the patient's underlying physiology. So on the one hand, we've got people who are insulin resistant, and that's one group to discuss. There are people who are insulin sensitive. That's another group to discuss. And both groups of people can be on a low carb or high fat diet and have a differential response to therapy. So let me answer the question in two ways. The first is that until you look at particle number, trying to understand the relative impact of LDL cholesterol is exceedingly difficult. And most people who are having conversations like this that are saying that low carb can be good despite increases in LDL cholesterol because triglyceride gets better and HDL gets better and measures of insulin resistance get better, are not looking at APO-B critically. And therefore, if I don't know APO-B going in, if I don't know the status of people's arteries going in, it's going to be very difficult for me to try to opine on whether the change in LDL cholesterol is meaningful or not. Second thing is, if LDL cholesterol goes up a lot, and we assume that means APO-B is going up a lot, in many cases that's true. If they were not elevated to begin with, and this is a new change for them, I don't know how long they have to stay in that state before there's a significant increase in plaque development. We assume that over time, if you stay in a very high APO-B state, all things being equal, eventually you are going to have increased plaque production. Now, what is the time frame for that? I don't know. And this is where Dave Feldman's lean mass hyperresponder imaging study is seeking to add information because we don't have it. And the assumption there is if you do a very sensitive imaging study, a CTA, and these people going in, and then they're allowed to stay on their chosen diet, which has unfortunately resulted in a high LDL, and you re-image them over a period of time, you'll see whether or not that is associated with an increase in plaque as visualized by CTA. So we don't know that data yet. That's a trial that's ongoing. It's going to help us have a more informed conversation about this, right? So that's one answer is we need to consider how long this APO-B burden has been present and against what backdrop it's playing out. Is there already plaque there? Is there not plaque there? Those two things, I think, change the conversation quite a bit. There have been large studies which have looked in women at various extended laboratory panels, and the impact of LPIR elevation on early vascular disease has been significant. So it is the case that LPIR has a discriminative ability to identify folks with increased risk for cardiovascular disease. That also overlaps with other biomarkers that are part of insulin resistance, such as APO-B, LDL particle number. So if you really wanted to try to tease that apart, you would have to do adjusted analyses where you take individuals who've been followed prospectively and say some of these people are going to develop cardiovascular events, okay? And then in that setting, you can look at not just the univariate or single variable association of LPIR, APO-B, LDL particle number. You can put them in the same model. And when you put them in the same model, what's happening is if I put LDL particle number and LPIR in the model, Do they both continue to independently predict, or does one continue to predict and the other not so much? I have seen analyses in certain populations where LPIR predicts by itself, LDL particle number predicts by itself. You put them in the same model, LDL particle number continues to predict, LPIR does not. That may not be true in all populations. That could be true in certain populations and not others, and it could have a lot to do with other details of their physiology, which makes this a dynamic, more complicated conversation. But the simple answer, this is the one variable which makes the most difference for everybody, is something that has to be unpacked for different groups of people differently.
Yeah, and so and the APO-B particle number. What about the APO-B APO-A relationship or the APO-A1 relationship? Because we often see, obviously, a lot of people see LDL go up, but also HDL goes up in some cases very significantly. Can those offset each other?
Not really. So the problem with APO-B-A1 ratio, you got a numerator and a denominator. One of the better trials to look at that variable was the Interheart study with thousands of people. And what you found is that a B-A1 ratio could either be favorable or unfavorable. And at the extremes, if you have a low ApoB and a high A1, that's very favorable, versus if you have a high ApoB, low A1, that's very unfavorable. So if you look at the odds ratios of people who are experiencing events, there's a line with a very high odds ratio. But the problem is in the middle, where you can make the same ratio by increasing one or decreasing the other. You can ask another question. In a populations of thousands of people, in the middle of that curve, not on the extremes, what is the individual variability of risk at the same ratio? And the answer is 40%. So there's a 40% range of individual risk variability at the same ratio. So the ratio is informative at the extremes, but in the middle, it loses its individual discrimination. So the other part of the HDL story that's interesting is that it is true that low HDL is an independent risk factor for vascular disease. It is true that higher HDL has less risk associated with it. We also now know that HDL cholesterols in excess of 90 are associated with increased risk of cardiovascular events and increased mortality. So there is kind of a curve there where too little is bad, too much is bad, and in the middle is where HDL has its best relationship with risk. And this goes back to the question that many people have asked, does HDL offset LDL? Well, over a certain range, a higher HDL is very helpful. But what happens when your HDL cholesterol is 90, 100, 110? Is that like super good because I have a super high HDL? Actually, current data would say that HDL function is more important than HDL quantity. And as we get past a certain HDL cholesterol, the type of particle that we're enriching is actually a poorly functioning particle that is not having the anti-atherosclerotic, antioxidative, anti-inflammatory, anti-infective effects that we would expect of HDL. And as a result, we are not having a linear protection by going higher. We get to a point where we've transitioned to a less functioning particle population, which happens to have a high HDL cholesterol, but we've lost the benefit. And now we're back to other factors that may or may not be present to offset what do I make of a high LDL.
Do we often see, with these extreme HDLs, 100, 110, 120, which I've seen a few people, do they often have a very high LDL in concert with that? And is it maybe the confounder of a high LDL is driving that effect perhaps?
They oftentimes, there's a range of LDL cholesterol. It's not the case that most high HDL has high LDL associated with it. Many times high HDL cholesterol can be a genetic thing, or it can be a combination of genetics and a variety of lifestyle things. Alcohol will increase HDL, exercise increases HDL. There are some toxicities that increase HDL that nobody really encounters.
Looks like he's frozen up here for a second. Hopefully he'll come back.
Well, if you obstruct bile ducts, you'll get a high HDL cholesterol. So there are a variety of reasons why that can happen.
Tell me about, there are some people that out there discuss the quality of these APO-B particles or the cholesterol or the lipoproteins, whether they've become damage through glycation, damage through oxidation, and it increases their atherogenic. What are your thoughts on that, and how does that modify the number, or does it make any difference?
Well, it does make a difference. So the first thing is that LDL that's not modified is rarely taken up by macrophages. So just an LDL particle that has not been oxidized or post-translationally modified is not a good substrate to be eaten by a macrophage. And so the whole story with atherosclerosis is that it's the particle taken in by a macrophage to form a macrophage foam cell that is the committed step of atherosclerosis. And until macrophages take in a large quantity of APO-B containing lipoproteins and then change their characteristics to become a very inflammatory cell that initiates and continues atherosclerosis, that's the committed step. So if you have LDL particles that are not modified, their impact on atherosclerosis is much less. Post-translationally modified LDL, oxidized LDL principally, is certainly a better substrate for macrophage ingestion, foam cell formation. And so the question then is, well, where does this oxidation or post-translational modification of LDL occur? The old theory was this occurred primarily in the wall of the artery, that circulating LDL was pretty much just LDL. It wasn't subject to many modifications. But once you get stuck in the wall of the artery, going back to the conversation we had earlier, you got this proteoglycan matrix. It has grabbed the LDL so it cannot escape. That trapped LDL is then subject to things like oxidation. That's one model. We also know that there's a model where you can get minimally modified LDL. So in the case of high PUFA or other things, LDL can become modified during its transit through the circulation, and that makes it something that's a little bit different when it gets to the wall of the artery, and that can further accelerate its atherogenicity. So there are many ways that LDL can be modified. It is true that modified LDL is more likely to be taken up by a macrophage. It's more likely to cause atherosclerosis. And it is true that the majority of LDL modification occurs in the wall of the artery, but not all of it. Some of it occurs during circulation. And what impact does that type of minimally modified LDL have? That's an ongoing debate. There are people who believe that that is an important contributor to atherosclerosis. There are people who believe that still what happens in the wall of the artery when the particle is trapped is the majority of what happens in atherosclerosis. I think it's probably a combination of both.
Yeah, it just seems the more you talk about this, the more nuance there is, and the sort of the reductionist sort of type of thoughts that doesn't work on anything in medicine or science generally. There's a fellow I've interviewed him, Dr. Malcolm Kendrick, who believes that atherosclerosis is primarily a phenomenon of thrombosis. I don't know if you've critiqued or looked at his sort of hypothesis. Any thoughts around that, or the thrombogenicity of blood contributing to some of this?
Yeah, so this gets into an interface, if you will, between a plaque and an event. So a plaque can sit in the wall of an artery. So I'll just pick up a little model, right? So here's my model of an artery. And in this artery, you see there is this plaque that's just sitting there. This plaque has various characteristics. It can be a plaque that has a very thick cap that does not have much inflammation, and its likelihood of breaking and causing a thrombus in an event is very little. Then you have what are called culprit lesions or unstable plaques. And unstable plaques have characteristics such as they're very inflamed, they have a very thin fibrous cap, they're very prone to some type of rupture. And if you crack the surface, then you have an interface between the plaque's interior and the circulation. And that is where thrombosis is part of the story. So that combination of factors then leads to some people have abnormal rheology or thickness of their blood, proteins in their blood. They have changes in their propensity to forming a thrombus. And if you put that type of person in an environment where you can get plaque rupture or plaque erosion, then there's a lot of contribution of thrombus to filling the vessel, putting people at risk for ischemia in an event. So a plaque sitting there by itself is unlikely to cause an event. Now, plaques can do this. Now what you see is a plaque that has grown in a way where it's limiting the amount of blood getting through the middle of the vessel. So now you have a flow limiting blockage. Here you have a blockage which is not flow limiting. So depending on the type of blockage you're talking about, non-flow limiting, inflamed versus not, versus flow limiting, you have lots of different characteristics that then interact with this whole question of thrombosis and rheology. So it is important. And without a thrombosis, your likelihood of having a cardiovascular event is very low. So it is the thrombus on top of some type of plaque event, which together puts people at risk for the acute ischemia and the acute coronary syndrome, which can lead to death of tissue or heart attack. So I don't discount that at all. Another guy in my world that's written a lot about this, Bob Rosenson, talked a lot about rheology back in the 80s and 90s, and the fact that there were nuances to risk that people had that weren't related to their LDL. It was not related to simple stable plaque, but had to do with this propensity for thrombus formation in the setting where a plaque either becomes eroded or cracked on the surface. And then you have the perfect storm where you get a rapid thrombus formation, fills the vessel, decreases or eliminates blood flow. And then you got to get to a place where they can open you up quickly or you're in real trouble.
You mentioned, we talked a little bit about imaging, and you mentioned CT angiography is, angiography being one of the gold standards, contrast angiography, which, this invasive. There's some people that don't need it. They're not, particularly if they're not symptomatic or there's not some other high risk event going on or process. So a lot of people are taking comfort in the coronary artery calcium scan. Like I mentioned, I had one. It was a 0 score. How the critics of that will say, well, it's missing all this soft plaque and a 0 score is meaningless. I would say that it probably isn't meaningless and probably predicts less soft plaque than having a positive CASK score. But what do you think about? There was a study out of, I think we mentioned this, I think it was Denmark, I believe, where they looked at zero CAC scores in symptomatic people and LDLs up to 190 plus, no increase in MACE type things, but there was a trend towards higher plaque deposition over 190. What are your thoughts on relying on the CAC score?
So that's getting a lot of attention in the guidelines. So CAC scoring has a lot of advantages. One advantage is that it's very standardized, it's very easy, it's very inexpensive. People can usually get it for $100 or less. And a CAC score, at least in the MESA study, Framingham, and other large data sets, is very predictive of 5 or 10-year cardiac event rates. So if you have a 0 coronary calcium, your 5-year event rate is very low. In many cases, your 10-year event rate is very low. So from the purpose of saying, am I at increased risk for an event, a 0 calcium score is very reassuring. So that's true. On the other hand, a 0 calcium score does not rule out the presence of plaque. And CTA studies, which is a virtual angiogram, computed tomography angiogram, has the ability to find plaque, which is soft plaque, not calcified. A good number of individuals with a 0 coronary calcium have plaque identified by CTA. So on the one hand, there is plaque there. On the other hand, a 0 calcium score is predictive of fewer events over a shorter period of time. Now, that can be very helpful for people who are older, right? So let's say 60, 70-year-old, 10 years is a very meaningful time frame. What about a 40-year-old? Well, a 40-year-old, 10 years gets me to 50. It doesn't get me to 60, 70, or 80. And there is the shelf life for the limitation of CAC scoring, because CAC scoring is less helpful for younger people, more helpful for older people. A 0 coronary calcium doesn't mean I have no plaque, as you said. There can be soft plaque there. But as I get into my 50s, 60s, and above, a 0 takes on increased significance of decreasing my risk. The guidelines actually talk about de-risking people, which I think is a very interesting concept. And I like it because, if you think about it, you have to be able to be healthy and older. That has to be possible, right? You have to be able to be a 60, 70, 80-year-old pretty healthy person. And if that's not true, then all of this is a house of cards. And the self-fulfilling prophecy is it's just a matter of how bad you are and you can never be good. So what does good look like? Well, insulin sensitive people, that's great. Good blood pressure, good diet, exercise, zero coronary calcium. This is all very reassuring, right? And should we be giving medications to people just because their LDL is less than optimal? I think CAC scoring is one of the things that helps us have a better conversation about that. This is what we do with the testing that we developed at Precision Health Reports. I mean, the question is, what's the totality of the person? What's your insulin resistance look like? What's your metabolic syndrome severity look like? What is your diabetic risk? What's the status of your vessels? And now we put all of that in context. Oh, and I happen to have an LDL cholesterol and an APO-B. So what happens if I have an APO-B, which is not favorable, but I have a zero coronary calcium? I think you're in a good place to have therapeutic lifestyle change and continue to monitor. I don't think those people have to be on the statin, right? Because we have no evidence of disease by CAC. We have otherwise good physiologic parameters. We've got an APO-B, which is not great, but something that can be watched and monitored, right? Now, that's a general statement. There are extremes of APO-B that I would feel uncomfortable leaving alone. If you give me an APO-B that's over 160, that's like the 98th percentile, I wouldn't leave those people alone. But more commonly, we're talking about people whose APO-B is 120 to 130, their LDL cholesterol is 130 to 160. Not great numbers. Do I medicate those people? No. The first thing is I want to work them up and see if there are underlying root causes I can affect. I want to try to optimize therapeutic lifestyle. I want to look at their imaging studies on their vessels. And the last thing is, according to the guidelines, we need to think very broadly about what are called risk-enhancing factors. There are over 40 risk-enhancing factors that contribute to vascular risk and have nothing to do with the calculation of 10-year and lifetime risk by the pooled cohort equation, don't have anything to do directly with other major risk factors. We're talking about things, for example, like psoriasis, rheumatoid arthritis, inflammatory disease. In females, preeclampsia, premature menopause, individuals who have other comorbidities that increase their risk. So if we're going to actually have a shared decision-making conversation per the guidelines, what we're supposed to do is take a comprehensive clinical history, add to that biomarkers, add to that risk-enhancing factors, consider imaging, integrate the 6 different U.S. and international guidelines that speak to cardiometabolic risk, and put all of that together for one patient at a time to have this better conversation than just what's your LDL. And that's what we put together at Precision Health Reports, a very simple method whereby people can answer a few questions online, get their blood work done, and then a report is generated that tells them all of these things so that they can have a better quality conversation like we're having today, not just, looks like you have no major risk factors, but your LDL is high. What should I do about that? I'll give you a statin because it's easy.
Yeah, that seems to be kind of lazy medicine, and I get it. I mean, many physicians, they've got 15 minutes, and it's just not enough time to really do the justice that needs to be done. And I think, like I said, I don't know why some people's LDL cholesterol goes really high, and I've never said ignore it, but I do think it's very nuanced, and you have to get in. Why don't we just measure? Why isn't the standard to measure APO-B now instead of the standard lipid panel? Total HDL, calculated LDL, and triglyceride seems to be, I don't know, is it cost effective? Is it that helpful? Is it less helpful than it used to be? Why don't we just go into APO-B directly?
Well, I have opinions about this, but again, I've spent 30 years seeking to understand the difference between measuring a particle number versus just measuring the cholesterol in a particle. And I can say I've lived long enough that many, but not all guidelines agree that APO-B is a better measure. It's more actionable. It's a better reflection of response to therapeutic lifestyle or medication. It is also, in a recent JAMA Cardiology, very large population, UK Biobank, plus the Fourier study, plus other studies, nearly 500,000 individuals. The only significant predictor in primary or secondary prevention of events was APO-B. It was not LDL cholesterol. It was not non-HDL cholesterol. The Europeans promote APO-B as a target of therapy. The Canadians promote it as a target of therapy. In the US, some guidelines give it as a secondary target of therapy, but it's not given as a target of therapy in the ACC-AHA guidelines. Part of that is cost. People say, well, it's going to cost extra money, therefore I'm not sure if the cost is worth it. But what is not in question is the following statement. If APO-B and cholesterol values disagree, they are discordant, risk always tracks with particle number. There is never an exception to that statement.
Yes.
Therefore, why on earth would I make LDL cholesterol my final answer when I know that it is not a good predictor of individual risk, and APO-B is much better?
Yeah, and you mentioned there's some degree of discordance, and it seems like insulin resistance increases that discordance factor by a significant amount, either up or down, typically up, I think, if I'm not mistaken. But do you have any concerns? I know I've seen people, with the advent of PCSK9 inhibitors saying that, it's perfectly normal to have an LDL cholesterol of 25. There's been no shown adverse events. I just wonder where that data is coming from, how reliable it is over the long term. I don't think we have data on people with LDLs of 15 over 40 years. Do you have any concerns with driving it down that low? I mean, even in the high risk populations, is there any concerns about dementia or any other potential issues? Because we know that there's an immune function role for cholesterol. We have, or some of these particles, they participate in the immune system, or at least they seem to. And then we also see all-cause mortality not inconsistently being a problem with low LDL cholesterol. At the tails, both ends, is kind of this U-shaped curve where, when you look at the all-cause mortality things, people will say, well, it's all just reverse causality. What are your thoughts on super low cholesterol?
So great question. There are two ways to answer that. There's a genetic answer and there's a therapeutic answer. So we do have experiments of nature where people live their entire life at very low ApoB and LDL levels. It's called hypobeta lipoproteinemia. And these individuals have lifelong low LDLs. They have very low rates of vascular disease. They don't have dementia. They don't have difficulty with growth and development. They make it to their adult years fine. The challenge they can have is because they don't make ApoB, they can't make ApoB containing lipoproteins like VLDL. And VLDL is how we get fat out of our liver. So our liver is making a lot of triglyceride and cholesterol. It's packaged in VLDL particles and sent on its way. If I can't do that, then what happens is you get to a fatty liver. And fatty livers are not benign. Many of them go into NAFL, NASH, non-alcoholic steatohepatitis. And so there is a reason why hypobeta patients can get in trouble, but it's not related to vascular disease or dementia or problems with low LDL. They're just not making the particles to egress their cholesterol and triglyceride from their liver. So one point of reference is hypobeta patients, and they do fine. The second thing is that what's happening in our blood does not reflect what's happening in our cells. And this is something that actually Brown and Goldstein talked about several different times, that looking at our blood for lipoprotein details of cellular metabolism is like looking through your garbage to see what's happening in your house. There's just not a one-to-one relationship. Every cell with a nucleus in our body is making cholesterol on demand. It's absolutely obligatory for life. And so if we have a low LDL cholesterol, and it got that way because we were clearing particles very efficiently after they've been made normally, we don't know of any downside of that. Another genetic situation, PCSK9 deficiency. People don't have the enzyme that we're targeting with Repatha, Praluent, or other therapies. And so they live their life with low LDL, no PCSK9. They have no issues with atherosclerosis. They don't have issues with dementia. They don't have issues with sex hormone production or physiology. So they do just fine. So the question of what do we make of a low LDL cholesterol, I think, is number one, is there genetic data that says low LDL cholesterol has a negative consequence over time to it? And the answer is no, with one exception, A beta lipoproteinemia. I don't make any ApoB containing lipoproteins. That's a 1 in a million problem. And unfortunately, these people have a horrible life. They go blind, they have neurologic issues, You have to have some APO-B containing lipoproteins produced, or you get into lots of problems. But once you make a little bit, hypo-beta lipoproteinemia, you're doing okay. So one answer to that is, yeah, those people live decades and decades and decades, and we have enough surveillance to know something about them. And you bring up a very good point, and that is PCSK9 trials are illustrative, but they've only been around for a few years. They haven't been around for decades. So I can't say I have decades of surveillance data on people that have taken PCSK9 injections. What I can say, though, is that when you look at the Fourier study, individuals with vascular disease who received Repatha plus statin had a median LDL cholesterol of 26, many of them down to 10 or less. And over the period of observation, those people did not have any signal for cognitive decline, no signal for adverse effects that was any different than people whose LDL cholesterol was 70, 100 on the statin only arm. So at least in a short period of time in follow-up in the Fourier study, we don't see that we have caused there to be significant adverse effects. And the third thing is the question of mortality. If you have a very low cholesterol in the setting of cachectic diseases, end-stage COPD, cancer, wasting diseases, these people have increased mortality. If you have low LDL cholesterol absent those things, there's not a signal for increased mortality. So that U-shaped curve has to be, I think, unpacked a little bit to understand who is it in that cohort of individual that are having mortality and what sorts of things are driving that.
There's a CRISPR technology where they are now looking at, basically modifying the PCSK9 gene to where it's either not expressed or it doesn't work as well in an effort to, I guess they're going to treat people with FH. I'm not sure who that's going to be targeted at, but some people would advocate everybody needs to have that. Does the PCSK9 gene or the protein that's associated with that have roles outside of just the reuptake of LDL? Does it have, or cholesterol rather, does it have any other function in the body that we know of?
So that has been looked at in different animal models. Interestingly, the question of, is there a downside to turning off PCSK9? I think the closest way to answer that are people with PCSK9 deficiency. And so the history of PCSK9 drug development was that they ran across a cohort of families that had very low atherosclerotic risk and very low LDL cholesterol. And they tried to understand, well, what's up with these people? And when they did their genetic analysis, they had no PCSK9. And so this was, the first step in saying, well, maybe that could be a target of therapy. But the rest of that story is, as you do surveillance of genomes, you find more and more people with PCSK9 deficiency, and you go back into their history and you watch them longitudinally over time, we don't see that there have been discrete physiologic abnormalities associated with the absence genetically of PCSK9. And while there are other functions that can be seen in certain animal models, we don't have an experiment of nature where PCSK9 deficiency has shown us that there is a downside to a CRISPR technology approach. And while it's not out there yet, it would not surprise me if one application of gene therapy could be familial hypercholesterolemia, trying to turn off PCSK9 permanently rather than pharmacologically. That's going to be something that gets a lot of interest, review, and critique and criticism. But in the future, we are going to, with, I hope, good thought and a lot of data going in, we're going to have opportunities to do some gene therapy on people. This would include people, for example, with sickle cell disease or people who have other single gene defects, maybe FH in the future. But, those are forward looking.
Yeah, that's going to be an interesting experiment to see. And, I'm sure some of those will turn out okay and some of them might not. And so it'd be interesting to see who's in the control group and who's in the experiment group and see how that goes. Tell me a little bit, Bill, we're running out of time, but tell me a little bit about your company, more about what you guys do, and then where does someone go if they wanted to sort of look into that?
Great. Yeah. So Precision Health Reports is a company that I co-founded with Matt Martin the purpose of which is to make the guideline recommendations as easy to apply as possible. The guidelines say we need a complete solution to cardiometabolic risk, and that includes clinical history, biomarkers, all risk-enhancing factors, and integration, harmonization of the U.S. and international guidelines. As you said, a guy who's seeing people every 15 minutes is going to be very challenged to do that manually. So what we've done is create a company where individuals who would want this report, the first step is that they would fill out online a series of answers to survey questions. It takes about 5 minutes. The second step would be they receive an email with a laboratory requisition to go to LabCorp and have blood drawn, and the blood that is drawn is lipids, APO-B, Lp(a), LPIR, Glycation, which is a measure of systemic inflammation, fasting glucose, hemoglobin A1C. Those labs are drawn. When they come back, the computer then integrates all of the above into a patient-specific report that tells people their insulin resistance status, their metabolic syndrome severity, their 8-year gender-specific diabetic risk, and their overall cardiovascular risk, not just informed by risk factors and the guideline calculation, but taking into account all of the risk-enhancing factors. The report also has a sheet which is generated based on the person's response and laboratory values that says, these are things that you might want to talk to your provider about. It does not give any specific recommendations for diet, exercise, or medication. It gives a representation of where your overall risk is, and you need to have a conversation with your care team. Therapeutic lifestyle is always the right place to start. In many cases, there's a prompt that says you might want to talk to your provider about non-invasive imaging. Because again, as we talked about, CAC scoring can be very, very helpful in many people, because what I have is a snapshot of where they are, but I don't have the rest of their clinical story. So there's really a need to fill in the blank, both with what's happening with the vessel, but also how are you doing over time? Okay, so here's your baseline. That's the initial report. There's also a follow-up report, which allows you to see side by side, where did I start and where am I now? I can see improvements. If I adopt a carb-capped intermittent fasting diet or some other therapeutic lifestyle change that significantly improves insulin resistance, I can see that. And that gives people a lot of motivation to maintain their changes, make it a sustainable change versus just a fad. So how they get more information, they would go to Precision Health Reports with an S, precisionhealthreports.com. On that landing page, they'll see information about the report. They can also order a report for themselves, or their provider can order a report for them.
Wonderful. Well, thank you, Dr. Cromwell. Thank you so much for spending the time and doing this and educating us on this. I think this is, like I said, this is a challenging, complicated, very nuanced topic. And like I said, it's nice to have a resource like that, because there's a lot of people that are very, reductionist out there on how they think it's, all cholesterol is bad versus it doesn't matter. And there's, usually the answer lies somewhere in between. Thanks for elucidating how, it's more complicated than we think. Maybe it's more, we've made it more complicated, but it probably is. So it clearly is. Thank you very much. And if you don't mind, I'd love to chat with you down the road again sometime about some more of the stuff, if that's okay.
Oh, absolutely. Thank you. And thanks for this platform. You guys do great work. I enjoy hearing the breadth of guests that you have on, and be happy to come back.
Absolutely. Thank you very much. And you guys have a great day to everybody else. We'll see you guys tomorrow. Take care, Bill. Bye-bye.